Hello, I'm Norman Swan. Welcome to this programme on tropical diseases. Australians are much more vulnerable to tropical diseases than you might imagine, and they can occur anywhere in the nation because of migration, travel and Indigenous acquisition. You'll find a number of useful resources available on the Rural Health Education Foundation's website, rhef.com.au. Let me introduce our panel to you. Bart Curry is an infectious disease physician at the Royal Darwin Hospital and Professor of Medicine at the Northern Territory Clinical School at Flinders University. He's also head of the Tropical and Emerging Infectious Diseases Division of the Menzies School of Health Research at Charles Darwin University. Welcome, Bart.
Thank you.
Bart's areas of interest include clinical and epidemiological aspects of tropical and emerging infections and development of treatment guidelines, as well as clinical toxicology. Anne Gardner has recently taken up a position as a Professor of Nursing on the Canberra campus of the Australian Catholic University. Previously, she was the inaugural Professor of Tropical Health at James Cook University, which was a joint position between the School of Nursing, Midwifery and Nutrition and the Townsville Health Service District. Welcome, Anne.
Thank you.
Anne's clinical research interests are focused primarily on infection control and wound care. John McBride is an infectious disease physician and clinical microbiologist, Professor of Medicine at James Cook University at Cairns-based Hospital Clinical School. Welcome, John. John has a particular interest in the tropical infectious diseases of North Queensland and the Western Pacific. He's studied dengue fever, HIV in Papua New Guinea, leptospirosis and rickettsial infections. Peter Shannon is a GP and is currently Medical Director of the Canberra Travel Doctor TVMC. He's also worked overseas in a TB screening program in Bangkok, as well as in a refugee camp in northern Thailand and as an embassy doctor in Laos. Welcome, Peter.
Thank you, Norman.
And welcome to you all. I mean, what do we mean, Bart, when we talk about tropical diseases? Just things that happen when it's warm and wet?
Sure, well I guess you've divided into what's happening overseas in the tropics and then what's happening in the tropical areas of Australia. We'll be focusing mostly on infectious diseases, but of course really the majority of problems these days are the chronic diseases that occur, particularly say diabetes, but also all the trauma such as motor vehicle accidents and things like that.
So things that people come back with, Peter?
It's much the same, and as Bart was saying, of course, the most important medical problems that Australians have travelling overseas are in fact the diseases they take with them, their pre-existing medical conditions, or the first manifestations of the sort of diseases we would see in Australia. But of course once they're there, they also suffer from car accidents, motorbike accidents, alcohol and drug related incidents.
So they take their blocked arteries with them?
They do indeed, but that doesn't stop them from suffering from what we might think of more as tropical diseases. Of course the diarrheas and gastroenteritis type diseases from what you eat, what you get bitten by, so malaria, dengue fever, Japanese encephalitis, rabies, those sorts of things.
Charming. John, if we look at Australia now, what's the pattern of infectious disease that we think about in terms of tropical infections?
Well, I suppose we've broadened our concept of tropical diseases and tropical medicine to include that fairly nebulous topic of tropical health, and that really deals with an ageing population or people with diabetes and other chronic diseases in a tropical environment, and they're interacting with infections and other heat-related conditions and humidity and so on that they don't have problems with down south. So it's a whole new spectrum of diseases that we're looking at apart from the infectious diseases.
So talk to me a bit about the infectious diseases.
Well, the diseases that in terms of the infections, we sort of varies from some of the viral infections. You've noticed up there that we're probably going to talk a little bit about dengue, but some of the bat-borne viruses and Japanese encephalitis, which is a mosquito-borne virus called an arbovirus, which is transmitted in the Torres Strait, and then moving through to some of the bacterial infections.
So that's an indigenous infection, Japanese encephalitis now? You can catch it in Australian territories?
So the area that has been exposed and suffering with, has been exposed to this infection is the people in the Torres Strait. So the northern Torres Strait Islands have annual activity of Japanese encephalitis. Now this is a virus which is amplified in pigs, picked up by the local mosquitoes there and transmitted to the local population, but of course there's a vaccination program there. So although we had cases many years ago, there haven't been any cases since the vaccination program started.
And do we have any indigenous spread of malaria?
We can certainly there are areas of Australia which are receptive for malaria, and there have been small outbreaks over the last decades in the Daintree. There was one in the early 1990s, and just last year there were some cases of malaria which were transmitted in the Torres Strait Islands as well, and that actually occurs a little bit more frequently than most people realise. But
And falciparum or vivax, which?
mostly it's vivax, although this year there were some falciparum cases occurring in the Torres Strait.
And going into the local mosquito population?
Yeah, into the local mosquito population. So we've got very talented...
You're scaring me here. So it's in. So is it still there in the mosquito population?
I haven't checked with the entomologist, but
Bit
I'm
cold
pretty sure
now,
that it's
yeah.
been knocked out. It's getting a bit cold.
Right. So it's closer than we think.
Yeah.
Not too far off. And in terms of nursing in the tropics, which you've got a lot of experience of, Anne, what are the issues there?
Well, a lot of the issues are to do with the fact that the protocols that nurses follow are protocols that are written for the southeastern corner. So things like the climate, the great humidity, high temperatures, those sorts of things mean that dressings don't stay on. Some of the really practical things are difficult. And the other thing, of course, is that just the vast expanse, so nurses are often sole practitioners in remote
So you're off in the
communities.
front line, recognising these infections.
That's exactly right,
and
yes.
disease. Is the burden increasing, decreasing, staying the same? What's the story?
Well, certainly the burden of some things is increasing because of the nature of our region. Dengue is definitely on the increase in the Southeast Asian region, and that's impacting on Australia. We're also seeing emerging things that have possibly been in our environment for millennia, but are now becoming evident, such as the bat-associated diseases, the rabies virus, or the bat lyssavirus, which is very much a rabies virus, and also Hendra. So these have been around almost certainly, but because of the interaction between humans and our natural environment, which is increasing, these are becoming evident in Northern Australia.
And what about seasons? Is there a huge difference between the wet and dry?
Yes, for us in Darwin, for instance, at the hospital, it's a massive difference. This time of year, in the middle of the year, we really like a southern Australian hospital with people who have come up as tourists, the grey nomads coming in with strokes, heart attacks, and then the wet season comes and things change completely, and we get a large amount of infectious diseases, which we'll be talking about.
And Peter, just talk to me. I mean, people get scared about things like cholera and so on. I think you've got a slide here which just describes how, you know, it's a bit of a reality check on what's common and what's not when it comes to infectious
Absolutely.
disease.
For the most part, the capital letter diseases are not common in travellers. That said, they do occur, and people are right to be mindful of that and to take the precautions that need to be taken. But yes, things like cholera certainly fall very low down the list.
And what about drug resistance that we're seeing people actually getting in Australia or emerging or coming across the Torres Strait? John?
Well, I mean, resistance is a problem everywhere in the world, but I suppose it's one of the starkest examples we have in Australia is the emergence of the multi-drug resistant tuberculosis, which we know is occurring in the western province of Papua New Guinea and coming across into the Torres Strait from travellers. As far as we know, it's not being transmitted in the Torres Strait, but that's one example. Other examples are people coming from the introduction of a very resistant bacteria like E. coli and Staphylococcus from overseas. So now, and I think Staphylococcus is probably something that a lot of people are very familiar with, and the proportion of resistant Staph aureus in our population in far north Queensland is approaching 40% of isolates are now resistant to the common antibiotics that we were using against Staphylococcus.
It's truly scary. Give me an idea of the risk management approach that you take, Peter, towards this.
For people leaving Australia, we of course first, as I've already mentioned, have a look at their pre-existing health conditions. We then need to look at where they're going, what they're likely to be doing when they get there, identifying whether the sorts of people they are doing the sorts of travel that they're planning to do are going to come into contact with particular things, identifying which they should be, and then we advise them on ways that they could minimise their risk. That might be a behaviour change, it might be a vaccination. In the case of malaria, of course, it might be prophylaxis. There's a whole range of things.
And in terms of the risk of getting the common problems, is that just the same as the risk you'd identify here? If you look as if you've got unstable angina, then don't go, that sort of thing?
Well, we don't try and say to people, don't go, but certainly we often need to be advising them what might be practical for them to achieve in terms of their travel plans, in terms of what illnesses they may have or conditions they may have to start with, and maximising their medication before they go.
And I'm a pregnant diplomat about to go to Cambodia, rural Cambodia.
Yes, that of course is one of the big hard questions. Again, we never say to people don't go, but it's very rare that travel is essential, and sometimes it's very easy to suggest that perhaps you could wait until a certain event has passed before you decide to embark on your travel.
I would say I have said to some people, don't go if they're pregnant to a highly malarious area, but that's just what I have said. But as you said, you can't always be accepted for what you say.
That's right. I mean, there are things that we can do. I mean, personal protection is a very important part of preventing malaria. I mean, anybody can sleep under a bed net at night. Anybody can wear long sleeves, long pants, closed shoes and a big hat to minimise the skin that can be exposed to mosquitoes.
Of course, bed nets don't work for all forms of mosquitoes.
No, but a bed net is better than no bed net.
True.
In fact, bed nets have brought the rates of malaria down, very dramatically in some endemic countries. So I think, the bed nets have been a real revolution in the control of malaria.
Although I understand if you go to around the Pacific, the Solomon Islands mosquitoes feed at different times from the Papua New Guinea mosquitoes.
Yeah, but I think even in Papua New Guinea and the Solomons,
they'll still have a chop at night.
Yeah, bed nets have been great.
Depends what time you go to bed as well, I suppose.
That's right. What are the biggest burdens of disease? I mean, we're talking there about, with Peter, for travellers, common garden diarrhoea is the one over all the rest. What about in Australia in terms of the common tropical diseases, apart from diabetes and heart disease? What are the biggest burden issues?
Well, I suppose we can look at it both from a numerical terms, and I suppose when we talk about numerical terms in North Queensland, then dengue sort of becomes quite a problem. And last year we had or 2 years ago we had an epidemic with over 1,000 cases in Cairns and surrounds. But when we talk about morbidity and mortality, then we're looking at diseases like Melidodosis, which affects mostly Indigenous people, but also with people who have immunosuppression or alcohol use, diabetes, and it can be a fatal disease for them. So there's much more morbidity and mortality associated with a disease like Melidodosis, even though there's far fewer cases. And then when we talk about things like tropical health, diabetic ulcers and so on, which are very common.
And you see a lot of scabies as well.
Yes, that's right. I mean, that's a huge problem. And of course it then opens up the possibility of other bacterial infections like staphylococcal and streptococcal infections.
Peter, we've had a question come in about vaccines. I mean, do you have to be a sort of highly specialised well, you'd say yes, of course, doctor, to know about the vaccines, or are there some rules of thumb here in terms?
I think it's most important about going back to first principles. Again, you look, who is the person who is travelling, where are they going, what are the risks, what are their risks of exposure to that, and then you say, well, we have a vaccine for this particular problem, it might be typhoid, and are there reasons why we shouldn't give this vaccination? Not often, and then we would offer it.
But then, but it is simple stuff like making sure your tetanus is up to date and...
Well, the routine vaccinations are very important, and tetanus is a significant one. Measles is another one. One of my favourites. I know it's neither tropical nor emerging, but it's vaccine preventable. And then you move into things like hepatitis A, typhoid, hepatitis B for longer term travellers, and then the more esoteric ones like the Japanese encephalitis.
So you don't use cholera vaccine in all your travellers, or...?
Cholera is a very popular word. It's in reality a very unusual illness for travellers to get, unless they're working in a refugee or a medical situation. One of the great benefits of the cholera vaccine we have is that it does provide some protection against some E. coli infections, and E. coli is one of the most common causes of bacterial diarrhoea in travellers. So it has a use for people, particularly people who might have another predisposition that would make it more likely that they would get a severe illness, a gastrointestinal illness.
And there's still some countries in the world which require yellow fever immunisation.
There are still many countries in the world that require yellow fever vaccination. None in our immediate region. They're all in either South America or in Central Africa.
And is there any cross-immunity with dengue for yellow fever immunisation?
Not that I'm aware of, but there's a lot of speculation about that, and I think there's a lot of work being done on trying to combine the two vaccinations or use one as a sort of to piggyback the other. A bigger issue is things like doing tests for these diseases and whether there's confusion if you've been infected with one
And we'll come back to that later when we're starting to talk about these particular illnesses. Let's go to our first case study. This is Mark, who's a 45-year-old Indigenous man from a top-end remote community. Comes to a local health centre with some fever and abdominal pain. He's had some symptoms for about a week. He's got type 2 diabetes, and here's the clue: it's during the wet season. Bart?
Sure. Well, I think the first thing is that clearly this is an infectious disease because of the fever, and so it's unlikely...
Well, it could just be the flu or food poisoning.
But that's still an infectious disease. So the question is, what sort of infectious disease here? It could be a virus, such as an unusual presentation of influenza, but the clue here is the wet season and the abdominal pain. And in the diabetic, what we have to do in the top end of Australia is think of Melidodosis. But of course, this could be some other infectious disease or even appendicitis with the fever. So it requires a good history and examination, of course.
So what is Melidodosis?
Well, Melidosis is a bacterial infection, and the bacteria survive in the soil, in the endemic areas, soil and surface water, and particularly during the wet season, these organisms, these bacteria penetrate through the skin, through open cuts usually, or through trauma. And occasionally with severe weather events they can be inhaled. And so Melidodosis in a healthy person may not cause much sickness at all, but if someone has one of the risk factors for Melidodosis, then it can be a very serious disease indeed. And because of the last two very heavy wet seasons in the tropical north of Australia, which is the La Nina cycles, we've had massive amounts of rain, and we've had 155 cases of Melidodosis confirmed with 20 deaths in the top end of the Northern Territory.
What do people die of?
And they die of septicemia, basically. 55% present with pneumonia, and they may often be blood culture positive. And then there's this other presentation, such as with the patient we're describing here, which is a genitourinary presentation with prostatic abscess. That's about 14%.
And what are the risk factors?
The risk factors: 40% are diabetic, 40% have hazardous alcohol intake, 20% have chronic lung disease, but importantly, 20% of people have no risk factor at all that we ascertain. Of those people with no risk factors, the 20%, it's very unusual for them to be critically ill. So you shouldn't die if you're a healthy person from Melidodosis if you get diagnosed and treated early. So healthy people get Melidodosis, but they may often present, for instance, just with a skin wound or a small sore.
And you can get rash, you can get skin manifestations.
The skin manifestations of Melidodosis are just like any streptococcal or staphylococcal infection, so they're not specific clinically. The important thing here is that if someone presents with a non-healing wound or sore which hasn't responded to dicloxacillin, flucloxacillin, cefalexin, then it's important for the swab to be processed by the microbiology laboratory on selective media, which will enable the organism, the Burkholderia pseudomallei, which is the bacterium that causes this, to be cultured out and make the diagnosis. So these skin lesions are very non-specific. So you have to think about it and then tell a lab, and they will then give you your answer.
And the other just blood cultures, is that the other way?
Blood cultures are very important because over half of the patients overall will be blood culture positive. So, and some people will be blood culture positive without any obvious system manifestation. So no pneumonia, no genitourinary infection, but just blood culture positive, presenting with fevers alone.
Any antibody tests?
The antibody test, the serology test, is available, but it's, the diagnosis is really made by culturing the bacteria.
And would you treat with a negative culture?
What we do is we have in our guidelines for people suspected of Melidodosis, we use particular antibiotics. For instance, we would use high-dose ceftriaxone, which will cover the other bacterial causes of that type of presentation, such as pneumonia, and we would only go to the specific Melidodosis therapy, which is ceftazidime, or for critically ill people, meropenem intravenously. We would only do that once we've confirmed that it is Melidodosis. The one exception being that if someone is critically ill and we think they may die within 24 hours, our evacuation teams now carry meropenem with them on the flight, on the planes, to give to people who they believe on assessment are potentially have a life-threatening septicemic shock.
And we've got some pictures of acute disease. One is the pneumonia, which looks pretty devastating.
I was going to ask, Bart, do you have trouble controlling the use of those broad spectrum antibiotics in those situations? Can you, is there a tendency for your registrars or doctors at the hospital to, think that their patients got melioidosis and they want to use the meropenem or the ceftazidime?
No. Our doctors are pretty good at following the guidelines, actually, John. So if they are ending up in ICU, then in the wet season we use meropenem on our critically ill people with sepsis in ICU. So that's the gold standard drug for confirmed melioidosis. But if they're not going to ICU and they're well enough to give time for the diagnosis, then they will either be on ceftriaxone quite often, or possibly Timentin, ticagrelor and clavulanic acid, both of which will cover and hold melioidosis, except in the critically ill people, until we have time to make the diagnosis.
And presumably this is an important one for nurses to pick up in remote
That's right,
locations.
yes, it is, that's right. And so nursing history is really important. Just, people have been exposed, whether they've got past history of diabetes, certainly if they've been cleaning up in the wet season, for example.
So look at the manuals.
That's right, yes.
Keep the old Bibles. Just take us through some of these other investigations we've got pictures of. We've got some more chest x-rays of fatal melioidosis, just to give you a sense of what it can look like.
So these are all people who died from melioidosis, just showing that there quite often is this upper lobe presentation on chest x-ray. 10% of the cases mimic tuberculosis, in fact, so they're not critically ill, but they present just like tuberculosis with night sweats, fever and a chronic cough. And they may be sick for a couple of months until they present and then have a sputum which cultures the bacterium. And so the differential very much for those is tuberculosis. This is a liver abscess, or a large liver abscess here in that person. And this is just showing this is 14% of our cases present like this with genitourinary infection. Obviously the prostatic abscesses in males, and that's just showing CT scan and ultrasound showing fairly large prostatic abscesses which do require drainage, and that's the pus that you can see there, which is aspirated. And indeed 20% of the males with melioidosis will have prostatic abscesses even if they present with, say, pneumonia or skin disease. So we do CT scans of abdomen and pelvis on all our adult melioidosis patients, because if they have a prostatic abscess, it needs to be drained.
Because presumably then it keeps on coming back.
Exactly. So before we started routinely scanning abdomens of people with melioidosis, we'd have some people who would have recurrent fevers over a period of 1 to 2 months. Presenting initially with pneumonia, and we were surprised their pneumonia was getting better, but they were getting fevers again. And then when we realised that these people in fact often had a hidden abscess somewhere in the abdomen, usually prostate, but could be kidney, psoas abscess, liver abscess, for instance.
Nasty stuff. Do you see much in Queensland?
Probably not as much as in the Northern Territory, but we certainly see enough to keep us keep us knowledgeable about melioidosis, and we're always appreciative of Bart's helpful advice.
And so tell me a bit more about parasitic infections that we should be concerned about.
Well, parasitic infections include they certainly include the scabies, which we've talked about to a certain extent, but one of the helminthic infections which can cause infection in, particularly in Indigenous population, is strongyloidiasis, which is a helminthic infection, soil-borne. This is a relatively common infection, but
we'll come back to this slide in a moment. Yeah. We'll just talk about strongyloides for a moment.
But it's important is mainly in relation to when people's immune systems have been compromised with high doses of steroids, or they're put on cancer chemotherapy. If they're harbouring strongyloides, then the strongyloides can actually reach very high concentrations and cause disease in itself. So,
and its presentation?
In that sort of state, it can cause pneumonia or CNS disease like meningitis, and usually the diagnosis is a bit of a surprise. But if we screen for strongyloides in people who are going to be immunosuppressed and treat the strongyloides before it becomes a problem, then that can be prevented.
So that's mostly in Indigenous populations?
Mostly in Indigenous, but in rural populations as well.
Look, the take-home message for us has been that it's incredibly important to get the message across that for any Indigenous person in Central or Northern Australia who's going on to more than 14 days of prednisolone at a dose of 20 milligrams for an adult or more, so 20 milligrams a day or more for 14 days or longer, strongyloides needs to be considered, because it's in that group that virtually all our cases of disseminated disease have occurred. And with the protocol which our rural staff follow. We haven't had a death for over 10 years from disseminated strongyloiditis by following that prevention of opportunistic infection protocol.
And the test is?
The test is a combination of serology and stool examination, and also we now in our guidelines in those high-risk areas, we're actually empirically giving ivermectin to people going on this immunosuppressive regimen. So if they fulfil the criteria for 2 weeks or more of immunosuppression, we then give them ivermectin as a preventative.
Talk to me about scabies.
Okay, well, scabies is a mite. It's a ectoparasite which burrows into the skin. It causes a lot of itching, and most people who have got scabies are well aware of the diagnosis. It's an intensely itchy condition, but there are two forms of scabies, and this first slide shows the classical scabies, which is usually between the fingers, often on the buttocks, and you can see down in the bottom left-hand corner there where someone's scabies has become infected with, probably with a staphylococcus, because you can see the pus coming out there. So skin infections after scabies are a big problem. But another form of scabies is this crusted scabies. Now, the classical form of scabies, you might only have a dozen or so mites causing a lot of itching and a lot of problems. These people have got hundreds of thousands of mites on their person, and it causes gross thickening of the skin. Treatment involves use of oral ivermectin, topical anti-parasitic drugs, plus keratolytics. It's usually a very long treatment. These people are isolated in hospital because they're highly infectious, and in fact normal scabies can be quite infectious too. If you can get outbreaks in nursing homes and so on, so it's quite easily spread around the hospital. So this is one disease where we do actually practice a lot of infection control and try to prevent.
So, and it's a major nursing issue.
Yes, it is, that's right. And nurses and Aboriginal health workers in communities can make a big contribution in terms of community programs, things like, there's programs like Healthy Skin, so encouraging the whole community to clean houses, improving washing, both the bedding, the person. The trouble is that a lot of the problems are outside of health, so it's good hygiene, good housing, reducing the number of people in houses and those sorts of things, access to good water supply, including hot water in the colder seasons when people might otherwise not want to wash.
And Bart, I mean, that crusted form of scabies can affect your general health quite significantly.
Yes, and until there were protocols to diagnose and treat this early, and also recognise that through those awful damaged fissured skin areas there can be bacterial sort of incursion into the body. Until it was recognised, the mortality was 50% within 5 years, and often these were people in their 20s to 30s years old, dying of sepsis from the bacteria that were getting in through those skin lesions. So now with the protocols that are available both rurally and in the hospitals when they get admitted, we're looking for secondary severe sepsis through the skin, but we're also doing, as John said, the very specific treatment protocols with multi-doses of ivermectin. So these people, the mortality is much lower now, but of course they will get crusted scabies again once they get reinfected back in their community. So we have to then implement, as Anne said, the community-based programs to try and prevent the transmission. And identifying these people with crusted scabies is important because what we've found is that in the outbreaks in a lot of the remote communities, there may be 1 or 2 people with crusted scabies who are core transmitters. So they're transmitting the infection, to many other people in the community because of the large number of mites that they have.
A question from Western Australia: should a doctor in the Kimberley region be alert to the same disease as a doctor in northern Queensland?
Bart, you're right in the middle of that.
Well, some people say the north, once you go north, just
there's
take a line from
certainly a lot of diseases
Capricorn.
which are common right across the north, but when we talk about dengue, for instance, that only occurs in North Queensland. Scrub typhus, we've got a lot in North Queensland, a little bit in Darwin. I think there's been one recorded case in the Kimberley. So different diseases have different patterns, but Melidodosis, I'm pretty sure that, and Japanese encephalitis, sporadic cases of that occurring in the Kimberley. So we've got a lot of diseases in common, but there are some important differences as well.
Yeah, I mean the fact that the dengue mosquito is not present in the Northern Territory or in the Kimberley means that we can't at the moment have local transmission of dengue, unlike in Queensland, but otherwise things are very similar. I will say there are different species of jellyfish, though, across the area, but that's, I don't think we're talking about that today.
No, we're not. A question for you, from Mr. Pillar, Peter. Should we be thinking of different diseases if the patient's a migrant versus being a traveller from overseas?
Different groups of people who return to Australia, whether they've arrived for the first time, or not returning, if they arrive for the first time or they're returning from travel, there are different risk factors depending, again, on who they are, where they've come from, how they've got here, obviously. And so it's always very important. It's treat everybody as an individual, and you look at where they've come from, what they've been doing when they were there, how they've got here, and from that you can make an assessment of what are more likely.
If you're a refugee from Iraq, you may have actually acquired diseases if you've been sitting in an Indonesian village for 2 years,
Absolutely,
rather than being your problem coming from Iraq.
Your dengue and malaria you don't pick up in Iraq, but you can get it on your way through. Yes.
So it's
You're sort of saying there are important differences between people who visit their friends and relatives versus the occasional backpacker, for instance.
Yes, absolutely. In Australia, being a country of migrants, of course, a category of people we call VFRs, visiting friends and relatives, returning to the home country, often for the first time, but not always. They are a high-risk group of travellers. They take less precautions, probably because they believe that they are of the area and therefore at lower risk, which of course is just not true.
A general practitioner asks, what factors should influence which malaria prevention medication is prescribed?
Really, it's going to sound like a cracked record. It's the same thing. It's where they're going, what the risk factors are, the likelihood of exposure. For example, you might think, well, all of Southeast Asia is a malaria area, therefore everybody going to Southeast Asia should get a malaria prophylaxis of some sort. If you're travelling mainly in tourist areas, then your likelihood of coming across malaria is much lower. And we might often decide that
because of spraying and it's an urban area.
All of those things. And countries that rely on tourism have figured out that if their tourists don't get malaria, they're more likely to say nice things about the country. There's no doubt up to a point there is some geographical differences. There still are a couple of places in the world where chloroquine can be used as prophylaxis, but we would never do that, partly because you can rarely get it. And why would you when you have very efficient other medications to use?
What guidelines do you recommend for anti-malaria? Which one? Do you use the Yellow Book or from the CDC or the Australian guidelines? Or
the CDC and also the WHO travel website are very useful. Some might say that the CDC is a little bit, being American, risk averse and perhaps not as realistic as some others. I like a resource called Fit for Travel, which is from the Scottish National Health Service, which has very good malaria maps and I think is a much more realistic reflection of risks of malaria.
Another question has come in from a general practitioner in New South Wales saying he's seeing more patients come back with bed bugs, sometimes from quite fancy hotels. Is there any health risk from bed bugs?
Well, they're a nuisance for a start, and you are highly contagious, potentially, if you have them. But I think the important message, as you say, is that we think of this as being the disease of backpackers, but it's not. In New York, they'll tell you it starts in the five-star hotels and works down.
And you can never get rid of them.
And you can never get rid of them, yes, in the hotel or in the patient.
Throw out the bags.
And the healing, I think the thing is, the main issue will be the secondary infections, which will be your own staphylococcal and streptococcal bacteria getting in there, and potentially, if you're, say, diabetic, you could actually have some pretty serious infection following a bedbug bite because of the bacteria that are on your own skin.
So be careful. Let's go to our next case study. Peter, 16 years old. He's an Indigenous young man from a remote Northern Territory community. He comes to the general practitioner at an urban clinic while he's in town for a foodie carnival. He complains of a swollen left knee and says he also has had a bit of fever. He's no known past history of illness except for some chronic suppurative otitis media as a young child. He can't remember injuring his knee during football games, and on examination he has a mildly hot swollen knee which, while slightly tender, the range of knee movement is decreased only slightly. His temperature is 38. He hasn't had any other joints involved. I mean, this to his heart, it's normal, no murmurs. John, what are you going to do for him?
I think the things to consider in a young man of this age is may have become recently sexually active, and one of the things you need to consider is sexually
gonococcal arthritis.
Gonococcal arthritis, and even chlamydia will cause an arthritis. So both of those infections will cause arthritis, and they certainly need to be looked for. But in this particular case, I think the number one diagnosis needs to be considered as rheumatic fever. Joint pain in any Aboriginal or Indigenous child up to this sort of age needs to have rheumatic fever actively considered.
Bart?
Yes, absolutely, and we'd always be recommending that a person presenting like this, even though they may not be very unwell, it is mandatory that they be admitted to hospital, is what we say in the Northern Territory anyway, for investigation of possibly rheumatic fever, workup, and then if rheumatic fever is confirmed, then the education process starts right there with our public health unit coming over and seeing the person and talking with them about their future as a person with rheumatic fever, rheumatic heart disease.
So these days, how do you make the diagnosis?
So the diagnosis is made, as it has been for a long time,
Major and minor symptoms?
Through the the Jones criteria, but there are revised Jones criteria, modified Jones criteria, and for the last 5 or 6 years there's been the Australian version of the Jones criteria, and we've actually lowered the bar for Indigenous people so that, for instance, a monoarthritis would not be considered traditionally as a major criterion. You would need to have polyarthritis, but for the Australian Indigenous context, our work over some years has shown that certainly they can present with a single joint swollen and inflamed, or indeed they may occasionally present with a polyarthralgia without actually an active arthritis. So those are some of the modifications that are made, so they can fulfil the criteria if they have a single joint swollen and hot and tender, provided you've excluded other things such as gonococcal arthritis, and also a polyarthralgia can fulfil the criteria, plus the other aspects of the Jones criteria. So as well as that, the next thing is the echocardiogram, which will establish whether they have already got valve damage. And that's critical, because it's the valve damage which eventually leads to fatal outcomes in, unfortunately, quite a few people still each year in Northern Australia.
And in fact, Peter is admitted to hospital and his arthritis resolves spontaneously, but his echo does show thickened mitral valve and mild mitral regurgitation. So he's had it for a while. Yeah,
well, what this means is that although this was his first presentation, he almost certainly had at least one and probably a number of episodes of acute rheumatic fever previously which had not been diagnosed, possibly because they might have been quite subtle, but also because they may have been missed when he presented to a health facility previously. And so what this means is he already has damaged valves, and the whole basis of management for here on in for this young man is to have suppressive or prophylactic benzathine penicillin, which is intramuscular injections once every 4 weeks, and that's to prevent further episodes of acute rheumatic fever, which unfortunately, if they occur, will lead to progressive valve damage and eventually a valve which either needs to be replaced or the potential for him dying of heart failure.
Now, I think we've got a picture here of an Indigenous child in heart failure, and that's a child who died.
Yes, that was a child who died at the age of 16 after a number of episodes of acute rheumatic fever and died in the intensive care at Royal Darwin Hospital. With this presentation was so unwell with this florid carditis that there was not, unfortunately, time to stabilise the patient and transfer somewhere where they could potentially have life-saving surgery. And so that still happens. Every year there are children dying in Central and Northern Australia and young adults with the complications of acute rheumatic fever.
Anne?
I was just going to say it's a really important disease for people who work in the top end to remember about, because people coming in as locums from Southern Australia, it's a disease that you see so rarely. So the people working in Northern Australia really need to kind of keep it in the front of their minds and remind locums, for example.
So, John, if you were working in New South Wales, you wouldn't necessarily think of this, would you? But you might see it occasionally.
Well, you should still consider it in New South Wales, and particularly in Indigenous communities, and people from the Southwest Pacific. Pacific Islanders have a higher incidence as well, and they've got a big problem in New Zealand with rheumatic fever.
But why is it a particular problem of the North? Tropics.
It's a disease of socioeconomic disadvantage. It's entirely an issue related to.
But why is it is more common in the North than it is
it wasn't more common in the North 100 years ago. It was incredibly important in Melbourne and Sydney up until the middle of last century, when there were people living in overcrowded conditions. So rheumatic fever has been recognised. It's not a tropical disease specifically. It's a disease of socioeconomic disadvantage.
And the acute treatment is penicillin G?
Well, the treatment, the penicillin is there to just eradicate the streptococcus from the throat, or if it is potentially on the skin, but it doesn't actually alter the course of acute rheumatic fever. What you need to do is give the benzathine penicillin to prevent further episodes. So the treatment of the acute episode is really just treating the fever, and then if there is heart failure, treating that, and then the inflammation will eventually die down, and then you hopefully prevent further episodes. The role of steroids is a little uncertain, but in florid cases, some people would consider using steroids.
And how often do you see chorea?
Chorea is relatively common as one of the major manifestations of acute rheumatic fever still, and so we get cases of chorea every year. And if people have chorea with their first episode of rheumatic fever, then if they were to get it again, then often they manifest as chorea the next time around. In addition, even though they may have just chorea clinically and their heart may sound normal, an echocardiogram will often show that they have a subtle damages to their valves, and indeed we always repeat the echocardiogram 3 to 6 months after an episode of chorea, and then we find that up to half of them have evidence of valve damage as well.
And there's guidelines?
Yes, look, I think that there are Australian guidelines which are consensus guidelines that are available on the web, and they're very thorough, and they basically talk about diagnosis and prevention and also secondary prophylaxis.
These are the consensus guidelines developed under the auspices of the Heart Foundation.
Yeah.
Let's move now to another case study. Susan, she's 25 years old. She presents to a doctor's clinic with a mild fever, headache and aching joints. She wonders if she has seasonal flu. They've been developing over the last 4 days. She came back from India, she tells you, 2 weeks ago after a 6-week holiday, and she's been experiencing diarrhea sporadically since her return. What are you going to do for her, Peter?
Well, common things occur commonly, and we should not rule out the possibility that she has the flu. But
it'd be far more boring if she had, but you know.
It would, yes, you can't make any conversation about that. A quick travel history, that she had a 6-week holiday in India will immediately should immediately erase the question of malaria, and for that matter, dengue fever as two common causes. It's very important to remember also that although fever is a cardinal symptom of malaria, many other symptoms occur with malaria infection as well, and diarrhea is not uncommon, coughs as well, and joint aches and pains occasionally also. So the presence of other symptoms does not exclude malaria. Interestingly, in this case, the other key factor is the time since she left India. Dengue fever and malaria are both spread by mosquitoes. Dengue fever tends to develop quite quickly, within 3 or 4 days of being bitten by a mosquito. If she's been back in Australia for 2 weeks, it's probably more likely that if this fever is of a tropical origin, that it's malaria, which takes a couple of weeks to develop, or can take up to a couple of weeks.
And can you tell clinically whether this is Vivax or falciparum?
I'm not aware of any clinical test that will differentiate. You need a blood test. You need a thick and thin film to make the diagnosis of malaria, and a competent microscopist should be able to tell you which strain of the malaria parasite it is.
Because nurses are often taught about temperature charts, you know, different patterns of temperature.
Yes.
But if you've got more than one infection, then that doesn't work.
Well, there's all sorts of confounding. Because temperature charts exist in textbooks for good reason. If you've been in India and you've been bitten by one mosquito and had one infective episode of malaria, then it's possible that your fever may follow whatever the course is for the particular strain you have.
You have to wait for an awful long time for that to develop.
And that's assuming all the parasites are of the same age.
Yes.
If you've had multiple infectious bites, it's all mixed up, and it's not really a good guide.
Having said that, if this woman developed a fever 3 or 4 months after coming back, it's much more likely to be Vivax than
That clinical
falciparum.
pattern absolutely suggests Vivax, yes, from the dormant hypnozoates in the liver.
Bart, what do you think of these new rapid diagnostics?
Yeah, well, there are some good ones and some not so good ones. The rapid diagnostic test, or the antigen test for malaria, is very useful and is being increasingly used worldwide. It is it's more sensitive for falciparum malaria than for Vivax, so there is a test for Vivax, a rapid test, which may miss some of the cases, but for falciparum it's particularly good. That's an antigen test, and particularly if there is no expertise in microscopy to identify the species of malaria parasite, then at least it gives you a positive and gives you an idea of which malaria it might be. The issue for dengue is a little more complicated in that there are some tests out on the market, they're including in Australia, which have false positives, so their specificity is not as good as the manufacturers would make you believe. And that can be quite dangerous, because we've certainly in Darwin had patients who have been told that they've got dengue on the basis of a rapid diagnostic test, when in fact, when we think, well, this doesn't quite look like dengue and test them for malaria, they indeed had malaria, not dengue. So the rapid test gave a false result. But there is a really good new rapid test available for an antigen test for dengue, which is called the anti-NS1 test, which is being increasingly used around Australia, and it has both good sensitivity and specificity. So it's a complicated area, but I think people need to be mindful that some of the rapid tests that are being pushed commercially can be quite problematic.
What advice do you give, Peter, for people going overseas for a long time, you know, an overseas posting to a rural area of Cambodia or something like that? I mean, is this doxycycline for your life or what?
In principle, of course, that's what you should say, and doxycycline is a medication that can be used for long periods, though very few people will ever remain on any medication for a long period of time, particularly as it's not giving them an obvious benefit on a day-by-day basis. All medications have side effects, and you know, other precautions against to protect yourself from malaria are equally important. Personal protection is very important. Insect repellents, bed nest to sleep under, we've spoken about. Dressing appropriately, long sleeves, long pants, closed shoes, and a big hat. Reduce the amount of skin that's exposed for mosquito
And how safe
bites.
is antimalarial prophylaxis for pregnant women?
Very difficult. Doxycycline, of course, as everybody would know, is contraindicated in pregnancy, although probably not, I think I can say this, in the very early weeks of pregnancy, and if you're on doxycycline and you discovered that you were pregnant and immediately stopped taking it, you probably don't need to be worrying too much. Other medications later in pregnancy perhaps are safer. Lariam might be safe, but...
And what about young children?
Difficult for the same reason. Of course, again, doxycycline is contraindicated. Relatively young children can take the alternatives, Malarone, for example, and Lariam, if you like, but newborns certainly can't. In the first couple of months of life, it's a very difficult issue.
There's a syrup formulation of Malarone as well, which is Malarone Junior. So, yeah.
Yes, there's a number of different formulations.
So, John, you live in Dengue Central, don't you? Tell me about dengue fever.
So dengue is we have quite a few epidemics in far north Queensland, and we've had epidemics in Townsville, Cairns, the Torres, and just more recently smaller cities like Innisfail and Tully have had epidemics. So it's usually brought in by a traveller, a febrile traveller, often not picked up or not diagnosed for whatever reason. We'd like to sort of be able to pick up more of those initial cases, but they infect our local mosquito population, and then epidemics ensue. So some of the epidemics are quite large. And 2 years ago we had an epidemic of over 1,000 people, but some of the epidemics are very small. Some of the outbreaks only are a handful of cases, but we've had 40 outbreaks since 1990.
So it's not truly endemic yet?
Not endemic.
Unlike this map, which is suggesting...
No, this is epidemic activity. The red area is areas that have got Aedes aegypti and have dengue epidemic activities. The other areas, which are in the mustard colour, are areas that have the Aedes aegypti mosquito, which is the vector for dengue, and they're receptive for dengue. So we noticed Africa before has a lot of these countries where Aedes aegypti exists. Now, it's likely that dengue does occur in most of those countries. It's just that it's not diagnosed because the laboratory facilities are unable to pick it up. So, and this is 2000. Things have progressed since then. So this is the Aedes aegypti mosquito on the right-hand side, and this is the virus on the left-hand side. And the Aedes aegypti mosquito, as we've discussed previously, is just concentrated in North Queensland, but there are other vectors like Aedes albopictus, which has moved into the Torres Strait, which has a tolerance for colder temperatures, and if that moved into Australia, you could potentially have dengue outbreaks further south than we currently have. The Aedes aegypti love human habitation. They breed in these containers, which are usually found around the house, so they're called anthropophilic mosquitoes. They love living with humans, so not quite as much with albopictus. So there's arguable whether they're as an efficient vector of dengue as the Aedes aegypti.
And the clinical aspects?
What's that?
And the clinical aspects?
Usually the classical dengue fever is high fever, headaches, and the headaches are usually with pain behind the eyes and pain with movement of the eyes, and the rash, which doesn't occur with every case, is usually a macular rash, and in this picture here you'll sort of see little islands of sparing, and that's fairly characteristic of the dengue rash. So this is a macular rash. It can vary from a light sunburn right through to the severe rash that you see there, and I think there's a more subtle one in the next picture. So a macular rash, not everyone has it, but it's a good clue when they do have it. Rash plus fever plus headache equals dengue, but it can be some other things.
But you would be thinking of dengue hopefully before the rash appeared, because it's not often the first.
Well, there's
sign
an
you get.
initial rash that they can get, and usually, but about day 4 or 5, the rash becomes more severe, and so they can get this terminal rash as well. So there's two different types of
So
rash.
we shouldn't forget the muscle aches and pains as well.
Oh, very severe muscle aches and pains. Yeah.
And it's important to actually remember that recently there's been an increase in measles coming in, and measles can be just like dengue, except they've got a really nasty cough and their eyes are often a lot redder, and they have the red throat as well. But measles needs to be thought about as well because it's on the increase.
We might be finding now that more doctors are more familiar with dengue fever than they are with measles diagnosis. So,
Don't forget the white spots in the buccal mucosa. And treatment is presumably just supportive.
Well, just for the classical dengue fever, yes, supportive treatment. But the reason we get excited about dengue is this occurrence of dengue hemorrhagic fever. So areas that have...
So what is dengue hemorrhagic? Because they don't call it that so much anymore under... I mean, it's supposed to be called complicated dengue, isn't it?
Well, the new WHO have brought out new guidelines, and they're calling it complicated dengue, but a lot of people know it as dengue hemorrhagic fever. So,
But hemorrhage isn't necessarily a strong feature.
But hemorrhage is a bit of a misnomer because a lot of people don't have the hemorrhage, as in this picture. Hemorrhage can be a feature of dengue hemorrhagic fever, but the main pathophysiology is hemoconcentration. So at about the time of lysis, about the 4th day of the fever, when the fever comes down, the capillaries become quite leaky, and you lose intravascular volume, you drop your blood pressure, the pulse goes up, and that person becomes shocked. And if they're not treated with intravenous fluid, it can be fatal. Up to 20% fatality rates in some countries before intravenous fluids were introduced, but in places like Vietnam and Thailand, where they're right onto this diagnosis very quickly and institute intravenous fluids, the mortality rate has been brought down to less than 1%.
And that's with second or subsequent infections with new serotypes?
That's correct, yeah. There's 4 serotypes, and it's usually the second or third.
And we've yet to see a dengue vaccine?
Well, actually, it's really exciting because a dengue vaccine has been trialled right at the moment in Thailand, including in very young children. And this is a vaccine, of course, made against all 4 serotypes. And there's a real possibility, you know, people say it's going to be 10 years till the malaria vaccine. Well, they've been saying that for 30 years. But for dengue, it's real. This vaccine is looking very promising. So that'll have a massive impact.
That'll be fantastic.
And there are other things that are happening in the dengue field as well, with modification of the mosquito. So they're introducing a bacteria into mosquitoes called Wolbachia, which makes them immune to dengue. So if these mosquitoes can outbreed the local population, that may also stop dengue. So there's some very exciting things happening in the dengue world.
We've had a question come in from a general practitioner in Queensland saying, you heard you talking about albopictus, and who's heard about chikungunya. Tell us about chikungunya.
Chikungunya is an alpha virus, very closely related to Ross River virus. So some of the symptoms are very similar, with aches and pains, but usually quite a high fever, a rash as well. So it's usually clinically confused with dengue, but there's a lot more joint pains of a type that you would sort of see in Ross River virus infection.
Do you die of it?
Sorry?
Can you die of it?
There were fatalities. There was a huge outbreak in the Indian island.
Mauritius or something like that?
Mauritius and Reunion, the island of Reunion, and then it moved up to India, and I think there were millions of cases in India.
And quite a lot of deaths. And so there were deaths from what they thought was an encephalopathy, which is of course very rare with Ross River. It's seen in animals with Ross River, but not humans. And there's also mother-to-child transmission of chikungunya, and it can be transmitted in the blood supply. So it's like a really revved up Ross River type virus infection with a number of complications potentially in the very old in particular.
And we've got these revved up mosquitoes in the Torres Strait ready to invade Australia.
Absolutely, yeah.
It's very comforting, this conversation. Let's go to our next case study. Steve is a nurse working in Papua New Guinea. He's diagnosed with TB whilst there and started on traditional standard 4-drug therapy. He comes back to Australia, but his TB does not respond to treatment. What are the next steps? Well, first of all, John, what's he liable to be complaining of? What are the symptoms here?
Well, the classical presentation for tuberculosis is with respiratory illness, so it's a lung disease, usually associated with night sweats, weight loss and a chronic cough, often with a little bit of blood in the cough. So we know that PNG is a highly endemic country for tuberculosis, driven by the HIV epidemic. And so Steve, if he's working with the population up in Papua New Guinea, would be pretty highly exposed to tuberculosis. So he's probably become infected and may have manifested those symptoms up in New Guinea. Now, up in New Guinea, the diagnosis would probably involve a chest X-ray, and if he was lucky, maybe a sputum smear, and he would have been started on 4-drug regimen. But they don't have the facilities up there at this stage to see whether the TB bug is resistant, and this is looking a little bit like it might be resistant because he's not responding to treatment.
How long do you wait before you see a response?
Usually within a few weeks they'll start to put on weight and the night sweats will go.
A few weeks? 4, 6, 8, what?
2 to 4?
Yeah, well, sometimes it may be as long as 4, and it may even be as long as 8 weeks in sensitive tuberculosis to actually become smear negative, sometimes even longer than that in some of the people coming in from overseas.
So are there tests to know whether or not you've got multi-drug resistance TB?
Well, the only way to know whether it's multi-drug resistant is to do resistance testing. Now, there is a new test that's being introduced in Australian laboratories. I mean, we've always had the capacity to test, but this is a very rapid test. It's a PCR test which looks for rifampicin resistance as well as looking for the TB organism itself. So it's a dual PCR which looks for TB and rifampicin resistance.
And why is it associated with HIV? What's the link?
HIV causes immunosuppression. So we know
but why
that
is multi-drug resistant TB linked to HIV? You can see why TB is, but why drug resistant?
Well, the multi-drug resistance story is coincident with the outbreak or the increase in TB cases. So multi-drug resistance TB was going to be here anyway, even if it wasn't.
So it's just because you've got a lot of TB, being treated with a lot of drugs, it's inevitable you're going to get resistance.
That's right, and probably the HIV epidemic drove that increase in the number of TB cases, but it's very hard to get treatment of TB right, and we need 100% compliance with treatment to prevent resistance from developing.
So that's where nurses come in looking,
That's right, yes. I mean, in the long term, it's about DOTS and directly observed treatment, so nurses are very important in terms of actually making sure that patients take their medications.
Now, I thought randomised trials had shown that DOTS wasn't effective.
Well,
I think that's interpretation of those trials. I think that the vast majority of people involved in public health around tuberculosis would say directly observed therapy is the best thing we have at the moment, while we're waiting for new drugs and for vaccines.
And so how much extensively resistant tuberculosis do we have on our doorstep, such as they have in South Africa, where there's almost nothing available?
Well, we're really fearing that from happening. There's been no cases of XDR TB, as it's called, that I know of in Australia.
From PNG, my understanding is there have been 2 cases of XDR TB in Australia diagnosed, but not from Papua New Guinea. So from PNG, there have been, as published just recently by Graham Simpson from the Cairns Tuberculosis Control Unit, there have been 40 cases of multi-drug resistant tuberculosis present in the Torres Strait, Papua New Guineans from Western Province, and so those 40 cases, a number of them had, in addition to the resistance to rifampicin and isoniazid, which means that they're multi-drug resistant, had resistance to one of the injectables, but they were still sensitive to the quinolone, so they weren't officially extremely drug-resistant TB. They're pre-XDR TB, but the next step, of course, is resistance to quinolones, which would make them XDR TB. Fortunately, quinolones aren't used much in Papua New Guinea. They're not available, but But in general, globally, the XDR-TB is on the increase, where there is all these drugs potentially being used. And there have been these 2 cases come in from overseas to Australia.
The message there will be, if you don't treat the TB right, you're going to get multi-drug resistant TB. If you don't treat the multi-drug resistant TB right, you're going to get XDR-TB.
resistant. And this chap would get quinolones? What would be his treatment for him?
Yeah. Quinolones and an injectable. He'd get a number of drugs, at least 4 drugs to which it's fully sensitive, and that would include an injectable and probably moxifloxacin.
And Peter, just before we wind up, just remind us about sexually transmissible diseases and overseas travel, and because presumably now we're seeing imported HIV.
We are seeing imported.
Well, not now. We have been since the 80s.
Yes, it's an issue of huge importance, and it is essential that anybody preparing someone for travel always include a discussion about sexually transmitted diseases. It can sometimes be very difficult. Perhaps it's easier with some groups of travellers than with others, but it's essential in all groups.
But travellers take a lot of risks, and I mean, our sexual health services up in Cairns see a dizzying array of sexually transmitted diseases and risk-taking of local travellers.
Yes, nobody would suggest that it's an easy thing to do or to constrain.
But it's something you need to think about.
Absolutely.
Yes. You know, with an additional infection. Thank you all very much indeed. What are your take-home messages, Peter?
When you see someone who's going away, look at them, look at where they're going, and look at what they're going to be doing to assess their risks, and then make some decisions about what they need in terms of advice and medication and vaccinations.
And if something unusual turns up in your surgery, ask where they've been recently.
Always. Travel history is essential.
John?
I think probably 2 from me, sorry. One would be think about dengue, even in areas receptive for dengue, because if you diagnose a case of dengue, you could potentially stop an epidemic from occurring. And always think about rheumatic fever in a kid with arthritis.
And you stop an epidemic because you keep that person away from mosquitoes.
From the local mosquitoes. When a person's known to have dengue, we're not aware of any case of known dengue starting an epidemic of dengue fever in the community. It's the ones we don't know about which start the epidemics.
Anne?
I've got 2 messages too. Nurses are just as important as doctors in terms of the history that they take, so keep have a broad idea about what all the possibilities are. And the other role for nurses is in prevention of things, managing things like scabies and strongyloides.
Bart?
Yeah, I guess for those working in Central and Northern Australia, there's a lot of resources out there that are available from people over the years who have worked on things, particularly the CARPA manual, for instance. First point. Second point is keeping close contact with the local public health unit who know what's going on across borders and about the notifiable diseases, and they can provide resources as well. And the third thing is that in most of the remote and rural health centres, there's a really good working relationship between the health workers, nurses and doctors who all work together to really improve health.
Thank you all very much. It's been edifying, if not a bit unpleasant in terms of some of the photographs, but a great programme, and I hope you've enjoyed it too, this programme on tropical diseases. We're grateful to the Australian Government Department of Health and Ageing for making this programme possible, but thanks to you for taking the time to watch and ask questions. If you're interested in obtaining more information about the issues raised tonight, there are a number of resources available on the Rural Health Education Foundation's website. That's rhef.com.au. Don't forget to complete and send in your evaluation forms to register for CBD points. I'm Norman Swan, and I'll see you next time.